So thank you so much for Ashley to organize this, Archbold to organize this. I think this is really heart disease is near to my heart. Obviously, you understand that because I train for it. But my biggest training and my biggest thing about treating heart disease, it's all about trying to prevent it from happening to begin with, okay? And that's what I'm really going to focus on today. I'm going to give you a little bit of background, and we'll start with that. So with that in mind, I'm going to just kind of talk to you a little bit about the outline of what my talk is going to cover. First thing we're going to talk about is statistics. Why are we here today, okay? What's the reason for us to do this health talk? Then I'll give you just a small lesson in anatomy because I think everyone needs to understand what their heart and cardiovascular system is about. And the next thing I'm going to talk about is just definitions. What is cardiovascular disease? What do we do with it? And how do we define it? The next thing I'm going to do is I'm going to just briefly talk about what are the most common symptoms that you or I will feel and what do we do about it, okay? And this is the acute symptoms that we're going to talk about. We're not going to talk about all the generalized symptoms, but acute symptoms. And then majority of my talk is going to be focused on risk factors and prevention. And then briefly I'll talk a little bit about treatment. But this is where most of my talk is going to be about. So let's just jump right into the statistics. Well, this is the grim statistics right here, okay? This is the 2013 National Center for Health and Human Services data, okay? This is deaths for men and women, and guess what number A is? Cardiovascular disease. Number one risk for dying, okay? This is what kills people in general in the United States, all right? So this is the reason why we are here, okay? And this really just specifies it by counties, okay? All right, so we are right here, okay? So we're sort of in the middle. We're not that bad, okay? We're right there. Here, I'll just point it out, right there. So we're sort of in the middle. We're not too bad. We're not really high compared to the surrounding communities. Obviously, we are a little better than them, okay? What about stroke? Okay? Right in the middle, this is the county that we're talking about. Next to us, obviously, they don't fare well. Okay, next counties. But we do okay. We're in the middle, but we need to get to this area. And how do we do that? Well, we'll talk about that today. All right, so let me give you a little lesson in anatomy. Everyone thinks, how many of you think that a heart is one organ? Most of you, right? It's one organ, right? Everybody thinks that. Well, I'm here to break that to you that heart is it is one organ, but it is really two separate parts. And let me kind of go over the anatomy of the entire cardiovascular system. And some of my patients actually probably have heard this before. But all the blood from your body, okay, this is the venous system. This is where the blood comes back to the heart. From the upper body and the lower body, all of that blood goes to the right side of the heart. There are two chambers in the right side. The upper chamber is called the atrium, which then goes through the valve called tricuspid valve because it's got three cusps, and then it goes to the bottom part, which is called the right ventricle. All right? All of this is a very low pressure system. Then this blood, which is deoxygenated, because remember that the tissues, your bones and muscles and all that stuff have consumed all the oxygen. So it has to be put back on the blood. So it goes to the lungs. And there is no connection between the right and left side of the heart. But first, the blood has to be filtered. It has to get rid of the carbon dioxide and get oxygenated again. All right? So this is where the lungs sit. Then it goes to the left side. The upper chamber, again called left atrium, and then the lower chamber called the left ventricle. Now this is the high pressure system, okay? And to let you know so that everyone understands, the workhorse of the heart is the bottom chamber right here, the left ventricle. Okay? This is what, if any of you are a heart disease patient, you are aware that you have been told that you have a dysnormal function or dysfunction, a percentage. You've been given a percentage. In general, in normal humans, our heart function is about 55 to 65%, which means that if you get 100 cc of blood into the left ventricle, about 55 to 65 cc of the blood will be pumped out to the, to the arterial system. And these are the arteries. This is the cardiovascular system, this whole thing right here. Okay? Like I said, heart is one organ but two parts, and the lungs sit in the middle. All right? This is very important to understand because a lot of the things that I'm going to tell you are going to come back to this, so relate to this. So everyone needs to understand this. All right, so let's talk about a little bit of definitions. In general, all arteries have the same type of process that happens, no matter what part of the body you are in. So the first thing that happens, you have a buildup of plaque. We'll talk about how the plaque forms and why it forms, okay? The second thing that happens is that as the plaque continues to build, the arteries get narrow, okay? And then obviously, towards the end, you're going to have significant decrease in blood flow to the tissues, to your bones, to your muscle, to your stomach, to whatever areas we're talking about, including the brain. And then that leads to less oxygen to the tissues. So in a more of a pictorial way we can show is that this is what the artery looks like. This is the inside of the artery. This is where the blood goes through. Okay, remember this is the high pressure system, not the venous system. And then a small plaque starts building, and it keeps growing, and then at the end, basically completely clogged off. All right? So what are the diseases that we deal with? Okay? If we have a heart arteries that have the same thing that happened, I just explained to you, well, you have a heart attack. And the arteries on the heart are called coronary arteries. So that's what the heart does. If this happens to your arteries that bring blood to the brain, those are called the carotid and cerebral arteries. Guess what happens? You have a stroke. All right? What happens if this happens to your arteries in your arms and legs? This leads to amputations. And I know most people think about the first two, but they don't think about the third one. And this is the reason why you guys are here today, because I want to give you the full system analysis, now rather than just tell you only about the heart, but everything else that goes through the arterial, because this is the cardiovascular system. Okay? So in pictorial view, this is what happens. You have all this plaque that forms and the blood clot because the plaque ruptures, and then the blood clot forms and you have a heart attack. That's what happens. What happens in the brain? Same thing. Blood clot blocks these artery that is plagued, and then it causes you to have a stroke. And then in the leg or arms, same thing happens. You have all this clog that's there, and then you have a small clot forms, and then all of a sudden you have no circulation, and that leads to possible amputations. Okay? So that's kind of what I wanted to just talk to you about, that this is a complete arterial vascular disease. All right, so I'm going to switch side, and I'm going to tell you a little bit about heart failure. What is heart failure? Okay? In the simplest terms, it's about the heart's pump. Okay? Bottom line is, it's unable to pump sufficient blood to the body. So there is a discrepancy between supply and demand. Bottom line. That's the simplest definition of a heart failure. Okay? So this could happen by two different ways. All right? Either the pump doesn't pump enough. Remember that I told you about that 55 to 65%? If it starts getting lower and lower, you're going to pump less blood. Or if the pump doesn't get filled up. So I haven't told you about this. So the heart has two jobs to do, okay? It has to not only pump enough blood, but it has to relax to fill up with blood. So heart failure can happen if the pump doesn't work very well or if it doesn't fill up. Now, we do a lot about the pump that's not working very well. We don't really do a lot. And when I say we, I mean physicians. Your doctors don't do a really good job in trying to take care of the relaxation part of the heart. Okay? That's because whenever we see an echocardiogram, ultrasound of your heart, and it says pump function is 55%, you ignore everything else. You just say, oh, yeah, my heart is working just fine. No, it's not. Okay? If it's not relaxing, it's not pumping enough blood, it's going to have the symptoms of heart failure. Okay? So, bottom line is either you have low pump function or the heart doesn't relax. All right? Eventually, it will dilate and it will fail. So in a pictorial form, this is what it looks like. This is your normal heart. Remember that workhorse I told you, the left ventricle, the bottom chamber on the left side. It starts to become bigger and bigger and dilate and start non-functional. Okay? This is the simplest definition of heart failure. Everybody understand that? Yes? Okay, very good. All right. So, sorry, this thing is very finicky. Okay. So what are the symptoms of acute heart attack? And now a lot of people are going to be surprised in this room when I'm going to tell you about it. What is a typical chest pain? Typical chest pain has three characteristics. Characteristics number one, it's in the left upper chest behind the rib cage. We call it substernal, retrosternal, because this is where the sternum is. So it's behind the sternum. It's all the same stuff, okay? So that's the first characteristic. The second characteristic is with exertion, when you're doing something, when you're exerting yourself, okay? And it's either relieved with rest or natural glycerin. These are the typical features. If you have all three, then you have typical chest pain. If you have 2 out of 3, you have what we call atypical chest pain. If you have 1 out of 3, it's called non-cardiac chest pain, or it's not heart-related. But guess what? Who gets these symptoms? Younger men without diabetes. That's it. That is it. The rest of the population gets totally different symptoms than what you get. And this is why I'm here to educate you guys that not everybody gets these typical chest pains. Okay? So I want everyone to understand that if you have other symptoms, okay, and I'm going to single out a specific group, and I'm going to tell you about them in a moment. But this is the groups that I want to single out. Women, older men meaning anybody above age 65, okay, and diabetics. They don't get the same typical chest pain symptoms. What do they get? They get short of breath, okay? And I can't put shortness of breath because the initials don't sound political, so that's why I wrote shortness of air, okay? All right? What else do they get? Particularly in women, what do they get? They get nausea and vomiting. They get indigestion. They don't get the same chest pain symptoms, okay? So this is the group of people that have silent MI, silent heart attacks, women. Okay? So you need to pay attention to your symptoms. If you are having these symptoms that are exertional, meaning they are coming on when you're doing something, you need to seek medical attention. Okay? And the last two things that I'm going to tell you about is that arm and jaw pain. We actually have a specific name for this in our cardiology world. We call it arm and jaw claudication. Claudication, very, very fancy term. All it means is jaw pain or arm pain that is with exertion. It is an angina equivalent. You guys may have heard of this term called angina. Angina is basically supply and demand mismatch. What does that mean? That means that the heart arteries are not getting enough blood to pump and function for the heart to work normally. Bottom line. Okay? So that's what that is. All right? So now, this is the typical picture everybody sees, right? man with the crushing chest pain. Well, this is why I'm here to tell you this only happens to younger men without diabetes. Everybody else gets different symptoms. Okay? So hopefully, if you don't take anything from my talk, at least you will know that chest pain is not always the typical chest pain that we are used to seeing. Okay? All right. What do we do when this happens? Okay? Well, first thing always is call 911. If you have a typical chest pain symptoms, the 3 symptoms that I described to you, even though they are not that chest pressure, even if you're getting short of breath with exertion, okay, and it's relieved with rest, that is still considered typical chest pain. If that happens and the pain doesn't go away, call 911, okay? Why? Time is muscle. Bottom line. The longer you have a heart attack, the longer the artery is blocked off, the more muscle mass you're going to lose in your heart. And that heart function of 55% that I told you about, you're going to start going down. Okay? So I need you to understand that time is muscle. And we'll tell you about the brain as well in a moment. Okay? I'm sorry. If you're not allergic to aspirin, chew a 325 milligram aspirin. Okay? This is going to save your life. It's been shown since the early 1980s that aspirin saves lives. Okay? So chew a full dose aspirin. All right? Now there are maybe some limitations. Some people will say that what if I have a really bad reflux, and what if I have very bad, maybe I have an ulcer in my stomach or whatever. Well, if you're having a heart attack, guess what? Even if you bleed, we're going to fix that. We can't fix your heart. All right? So chew an aspirin. All right? Rest. Sit down, because if you have a specific artery that is blocked off, it can actually lead you to pass out. Okay? So be very, very careful. And the older you are, the harder it is for you to actually have fall and a bone break and everything. And if you have a broken bone on top of a heart attack, it's very hard for us to deal with that as physicians. Okay? So sit down. And last thing, if you do have nitroglycerin, if you have known heart disease, then put one under your tongue. Okay? And you can repeat that every 5 minutes up to three times. Now, this is the party line. I have to tell you that we can repeat up to 3 times. I tell all my patients not to do more than twice. Why? Because what does nitroglycerin do? It drops your blood pressure. You may even pass out just by taking 3 nitros. So don't do that. Before you take the nitroglycerin, always call 911. So you already have help coming to you. Okay? Everybody understand that? All right, so now we got that out of the way. What about acute brain attack? I'm not going to use stroke. Stroke is such a bad word to use because people ignore it. I'm going to call it acute brain attack, which is what we call in American Heart Association, American Stroke Association. That's what the definition is, acute brain attack. Okay? What do? Okay, so the first thing is you've got to recognize your symptoms. These are the typical symptoms, and I have an acronym that I want everybody to remember. All right? The first thing is sudden facial droop. You see one side or the other side of the face that is lagging compared to the other side. Okay? Sudden arm or leg weakness, and that could start out as numbness, but then it becomes weak. Numbness could be many, many things, but it's the weakness we worry about. Okay? And there's a very easy test to do, and I'll show you guys that. Okay? And unable to speak coherently. Whatever they try to speak, nothing comes out, or their speech is garbled. Okay? They're trying to say something, but they don't make sense. All right? These are the symptoms. What other symptoms? Sudden dizziness and unsteadiness. Okay? This is something that people ignore. All right? So this is something that I want you to pay attention to, the dizziness and the unsteadiness. Well, this could be a stroke in the midbrain area, which could cause you to have balance issues, but nothing else. So you need to keep a very close eye on that. And the last thing is sudden severe headache. Okay? I know every single person in this room, I have to say, has had a headache in their life once in a lifetime. Okay? And some people will say that I've had the worst headache of my life. I'm sure of it. I'm sure of it. Okay? But if you have a sudden onset, majority of the headaches are usually going to become gradual. You feel like there's some little bit of pounding headache, and it gets a little bit worse, a little bit worse, a little worse. But if you have a sudden severe headache, to the point where it just basically make you crawl, just kind of put you down, that's the symptom that I'm talking about. Okay? The last thing I want to talk about, and this is another thing that people ignore, sudden vision loss. Okay, all of a sudden, one part of the vision in your, visual field just basically goes away. Or you start seeing lines in there, or you start seeing something different in there. All of these symptoms are acute brain attack. Okay? So, there's an acronym called ACT FAST. Okay? And it's very, very proper. This was designed by the HASA. So, this is what we use, okay? F stands for face. So is there a droop? Do you see this person having a little droop on the one side compared to the other side? How do you make that determination? Have them smile. If they smile and one side does not lift up, you know that they have a droop, okay? Second thing, arms. Simple. Make them just bring the arms into the front. And if that one arm just starts dropping like this, then you know that there's a weakness. Okay? This is just a very common test that you can do. Okay? Speech. If they're starting to speak something slowly or it doesn't make sense, or they're trying to say something but nothing comes out, that's a problem. And the last part of the acronym is FAST, which is the time. Okay? And why is that? What do? Call 911. Okay? Why? Because, and I'll tell you about this one. I'm going to skip to this one. I'm just going to get to hospital immediately. And here's the reason why. Time is brain. Just like the heart, this is acute brain attack, just like the heart attack. Okay? Time is brain. And I'm going to tell you a little bit about, from my research background, about the heart and the brain. There's a slight difference between two organs. But if we treat this within the first few hours, there may be less, sometimes no significant brain loss. Now, there's a caveat to that. I didn't put a star next to it, but I'm going to tell you that there may be brain loss, but no symptoms, no symptomatic brain loss. Okay? Meaning a person will be completely functional. All right? We may see it on MRI that you've got a little brain loss there, but it may not be anything physiologic. We won't be able to see any symptoms of it. All right, now I'm going to come back to number 2. Check the time, when normal, when abnormal. Why? Because we meaning the prior researchers have done significant amount of studies. And what they've found is that there is a specific time when patients can benefit from doing intervention by giving clot-busting drugs to get rid of the clot that's going to the brain artery and actually prevent you from having significant damage later on. And that cutoff changes all the time, okay? And certain larger centers will have even a longer time because they can do some sort of invasive procedure where they can actually go into your artery and deliver the clot-busting drug right there in the artery. And that can be done up to 12 hours. But typical time is usually about 4 hours, okay? For any hospital that has a level 1 trauma center, which is Archbold, okay? So this is the time. So you need to know when a person was normal and when they were abnormal. Let's say you saw your loved one completely normal the night before and they woke up with a droop or they couldn't move or do something like that. Well, unfortunately, this is one of those scenarios we don't know when the time was, so we may not be able to treat them appropriately. And that's just because those are certain limitations that we have. Because what we have found is that if you did not meet that 4-hour criteria, you may actually not benefit and we may actually cause you harm. Because what are these clot-busting drugs? These are blood thinners. They can cause you to have bleeding. So this is the reason why there's a timeline for that, okay? All right, the rest of my talk is going to be about the prevention. So let's talk about risk factors for your cardiovascular disease. Okay? What are the top major modifiable risk factors? Meaning the things that you can do to prevent heart disease. And I'm going to put tobacco in number 1. Okay? And I'm going to come back to about why and all that stuff. And this includes both smoking and chewing. Okay? And the next one is high blood pressure. And I will guarantee you guys that so many in this room have not checked their blood pressure routinely, or if they have a history of blood pressure, elevated blood pressure, and they're on medicines, that they don't check their blood pressure twice a day like we usually recommend you to. Okay? And guess what? Majority of the diseases can be put down to just one cause, high blood pressure. Remember I told you guys about that heart relaxation part? Well, remember, when you have high blood pressure, what does the heart have to do? It has to push against that very high pressure. Imagine a rubber band. You stretch a rubber band for long periods of time. You let it go. It's not going to come back to its normal shape. The heart is sort of the opposite. If it keeps pushing against this pressure, it's not going to relax very well. And this is where the start of heart failure with normal function starts. Okay? So I want everybody to understand that this is a major risk factor. The next risk factor is elevated cholesterol. And I guarantee you, everybody in the South is guilty. Like Ashley told you guys. I grew up in Texas. I grew up in the fattest city in Houston for quite some time. Okay? So I came from a very, very, very unhealthy city. And in the South in general, I will tell you, we do 2 things very, very, very nicely. Okay? Number 1, we eat the quota of the entire day's salt in the morning. And number 2, we eat the quota of your cholesterol in the morning. Okay? For the day. So this is what we do. This is how it works. Okay? That's just the South. That's how we have grown up. But unfortunately, this is a bad thing for you guys. Okay? And diabetes. Okay? Now, there are 2 types of diabetes. This is not a diabetes talk. I won't go into that. But I want to just focus on one type of diabetes. This is the acquired diabetes. The thing that happens to you as you go along. Okay? It takes 15 to 20 years for the pancreas, which is your organ that releases the control for the sugar, for you to develop diabetes. So it didn't happen overnight. Okay? So it takes 15 to 20 years. All right? We know that. So that's one of the reasons why we say this is a modifiable risk factor. And guess what? 4 of these account for 90% of cardiovascular disease. 90%. Okay? So this is why I put that on a separate slide. Now, let's talk about just some other modifiable risk factors. These things that you can do to modify. All right? One is poor diet. We'll talk about that. We'll talk about obesity. We'll talk about psychosocial stress. Okay? We'll talk about just a little bit about physical inactivity, and we'll talk a lot about how we're going to fix that. Alcohol use. I'll give you some numbers about what is considered appropriate and what is not considered appropriate consumption. And no type of illicit drug use is considered normal. No type. Doesn't matter what kind it is. Okay? Now, some of you will say, you guys are generous. Some of you guys are baby boomers. Some of you will say that, what about marijuana? Well, we'll talk about that in a moment. Okay? Use of certain medications. And the one that I want to really focus on is the anti-inflammatories. So many of us pop ibuprofen, naproxen, all those things like candy. Oh, you got a little knee pain? Take that. Oh, you got a little headache? Take that. Okay? And some people take it regularly for whatever their ailments may be. And I'm going to tell you that all 9 of the anti-inflammatories have variable risk factors for cardiovascular disease. Okay? All right. Other inflammatory diseases, and we'll talk a little bit about that. And when I'm talking about inflammatory diseases, I'm talking about rheumatological diseases. Okay? Rheumatoid arthritis, lupus, other things. Okay? And the last thing, two last thing is, socioeconomic status. And this is something, although it's put in the modifiable risk factor, sometimes the circumstances are, you can't change that, okay? All right, so what about the risk factors you can't change, no matter what you want to do? Well, there's no fountain of youth, guys. So you can't change age. As you get older, you get more disease. That's just the bottom line, okay? Gender. Well, we have a gender bias in pretty much everything. Well, guess what? Cardiovascular disease is not fallible to that either, okay? Men tend to have a earlier disease, age 45 plus. 45, guys, 45. Most of the people in this room are probably close to that or older, okay? So we are all at risk for heart disease. Females, a little bit later on, okay, 55 plus. And guess what protection they get? The hormones they have, the female hormones we call it, okay, they actually protect against the heart disease, interestingly enough, okay? All right, ethnicity. Unfortunately, race is is also biased to get heart disease, okay? In particular, African Americans, Hispanic Americans, Native Americans, and Native Hawaiians, they have the highest coronary artery disease risk, okay? And African American, Hispanic Americans, Chinese and Japanese have the highest stroke risk, all right? And this is all from population studies. We've looked at multiple people for long periods of time. We've followed them and we found this, all right? And family history. You can't change your family. You're born into it, for crying out loud. Sorry, you can't change it, even if you want to, all right? So if you have had your brother or sister, your parents or your grandparents have heart disease, guess what? You also have risk for it, unfortunately. All right, now, heart failure risk factors. This is slightly different, okay? This is something we're doing it to, okay? Remember what I told you about the blood pressure? Number one cause of heart failure admissions in the United States. Number one cause. Yes. Because guess what? 50% of the admissions for heart failure have normal heart function. Normal heart function. Normal pump function. The 55% that I told you guys about. Okay? So where did the heart failure come from? It's because the heart wasn't relaxing very well. It was pumping against all that high pressure. Okay? Clearly, this is what we have to change. All right? The second thing is obviously coronary artery disease, because this is what causes your heart, your pump to fail. Okay? Your heart function, the 55% starts going down, and then your pump won't work as well. All right? Makes sense. The other one is rhythm issues. This is something very specific. If you have a rhythm problems, atrial fibrillation, ventricular arrhythmias, all these arrhythmias can put you in heart failure. This is something that is also treatable, but it's a known risk factor for heart failure. Next one is drugs. This includes both illicit drugs, meaning illegal drugs, and legal drugs, drugs that we give you. Okay? So the most common drugs that we're talking about is chemotherapy drugs. Okay? That's one, and the new biologic drugs that we use for rheumatoid arthritis, inflammatory bowel disease, all those things, okay? I'm sure you guys have heard of it, Humira, Remicade, all those things that you guys have heard of on the TV commercials. All of these medicines can cause you to have heart failure, okay? Not everybody gets it, unfortunately, but some people do, all right? And then this is a separate category, congenital heart disease, structural heart disease, and then valvular heart disease. In fact, I'll give you a very nice example. Just took care of a 44-year-old lady this over the weekend. She came in with shortness of breath, okay? Guess what? She had rheumatic mitral valve stenosis. Remember the mitral valve I told you about, the one between upper and lower chamber between the left side, okay? She had rheumatic fever as a child. Nobody really paid attention to it. What are the two most common characteristics of rheumatic fever? Fever and joint pain. That's it. Lots of kids get that, right? But we have forgotten how to treat it. Okay? If she had gotten antibiotics when she had that fever, as a child, she would not have a heart valve that needs to be replaced now. She's only 44 years old. Okay? All right, so that's the valvular heart disease I'm talking about. All right? And the rheumatological, we talked about it already, rheumatoid arthritis, lupus, and things like that. Infectious, okay? Infections can actually cause you to have heart failure. How does that happen? Well, infections cause you to have your valves not work properly and everything backs up. Okay? And that's how it does that. Pregnancy. Guess what, guys? Women, if you get pregnant, you're at risk for heart failure. Okay? Now, I knew this was going to get a chuckle out of it. That's why I put a little exclamation point next to it. So just because you got pregnant, you are at risk for heart failure. Okay? This is another one is 9-to-1 for women to men. Okay? Stress induced. We actually even have a special name for it. It's called Takotsubo's cardiomyopathy. Okay? Dr. Takotsubo described this. This is very common stress induced. I have taken care of so many women whose husband has died or who have just given the diagnosis of cancer or something like that, some very, very stressful event, and that a heart function goes down from 55% to 25%. We do a heart catheter, we find no disease in their arteries at all. And then a week later, their function is completely normal. Okay? So this is stress induced. And then we claim a category called unknown, idiopathic. We don't know the cause. We think we know, but we don't know. Okay? Most commonly, it's the viruses. It's called viral cardiomyopathy. We just don't understand them very well. Okay? At some point in your life, everybody's got a cold. Okay? So you've got a viruses. Guess what? Our body, our cells, our human genome has 30 viruses incorporated in it. So we really don't understand viruses very well. So that's the unknown part of it. All right. So now the major part of my talk, prevention. Stop smoking. Stop chewing tobacco. I told you I was going to go back to that. Go see your doctor regularly. Now, there's specific things I want you to see your doctor for. Remember that blood pressure I talked to you about? High blood pressure. Get it under control. Get your cholesterol under control. Remember, these are the 4 major risk factors. Smoking, high blood pressure, cholesterol, and what was the last one? Diabetes. Get your diabetes under control. Okay? So this is where the prevention starts from, right here. What about other things? Remember we talked about poor diet as one of the modifiable risk factors. Obviously, you need to eat a heart healthy diet. We're going to talk about it. Okay? We're going to talk about losing weight. We'll talk about reducing stress. And this is where people have to figure out what is the best stress reliever activity you want to do. Whatever it is. You want to go to church. You want to volunteer. You want to go out play golfing. You want to go out fishing. Whatever it is, go do your stress reliever activities. Keep stress level low as much as possible. And there are times in regular day-to-day life, you can't do that. But it happens. Okay? Become active, and we'll talk about that. This is just, I'm just putting it as a disclaimer. 30 minutes daily. I'm sure you probably saw my face and me recommending you guys to do 30 minutes daily in one of the newspaper advertisements. Okay, reduce alcohol use. So this is where I'm going to tell you what is the appropriate amount of alcohol that you can take. For men, less than 2 drinks a day and total of 12 drinks a week. That is considered appropriate. Less than, okay? If you take more than that, you are at risk for alcoholism. Okay? Now, guess what for women? Less than 1 drink a day and less than 7 drinks for a whole week. If you drink more than that, you are at risk for alcoholism. Okay? Now, I'm sure some of you are going to ask me about red wine and all those things. We'll talk about that at the end. All right. And like I said, no illicit drugs, period. All right. Talk to your doctor about your medications. We talked about the anti-inflammatories, which they're called non-steroidal or anti-inflammatory drugs. Okay, that's what NSAID stands for. Okay, all those anti-inflammatories will cause you to have increased risk. There's only one exception to it, which is aspirin. But if you take it every day, that has other consequences. Okay, in women who are in childbearing years, oral contraceptives, okay? And then in women who are postmenopausal, hormone replacement therapy. And this is very well known, and the OB-GYN do really excellent job trying to prevent this from happening, okay? But definitely talk to them about the NSAIDs, okay? All right. Now, get your rheumatological disease under control, okay? If you have rheumatoid arthritis, or if you have lupus, or if you have other things, okay, you need to get it under control. And if that means that medicine that, remember we talked about Humira or Dermicade, that could potentially cause you a heart failure, well, sometimes you may have to take that to get it under control, okay? So I just want you to be aware of that sometimes we have to take the lesser of the two evil at a time. Because heart failure we can treat, rheumatological disease. If you're not under control, things will get worse, okay? All right, this is where it starts, okay? All right, so how to quit smoking or chewing tobacco, okay? The biggest battle is make up your mind. It's mind over matter. 90% of the battle, okay? And then obviously ask for help. This is what we are here for, okay? Now, there are some tobacco substitutes that I really like to have my patients. The most typical one that I would recommend is obviously the patch, okay? Some people say gum, some people say other things. Medicines, yes, they advise it all the time. You've seen, how many of you have seen Chantix advertisement? Almost everybody. I'm sure of it, okay? If you look at long-term data, at the end of the year, patients who did it cold turkey or they took Chantix to quit, guess what the numbers are? 23% were still smoke-free with Chantix, and 21% were smoke-free with cold turkey. 2% difference. Is it worth it to take the medicine? Probably not, okay? I'm not here to say that don't take it. If it helps you quit, anything helps you quit, take it, okay? Or do it, all right? The only thing you can do is e-cigarettes. And if someone has a question about why, we'll answer that later, okay? Other programs, and I'll give you a little bit about that, okay? The second part is once you quit smoking, fight the urge to start back, okay? So many of my patients tell me, oh, I had a heart attack, I stopped smoking, and 2 years later I see them, they started again. Fight the urge to start back, okay? And this is where peer pressure gets to most people. People see other people smoking, and they start smoking again. They miss it. It's the brain again, okay? And then this is the other big thing that I tell all my patients. I don't know about anybody else, but I tell all my patients, you have to make around you quit. If you have your wife or husband, your children in the house smoking, you will not be able to quit. Everyone has to quit, okay? And this is what I was going to tell you about, okay? So Archbold has a program with the Oncology Center, okay, for free smoking cessation classes. And at the end of my talk, I'm going to have a phone number for you guys. So if anybody wants help to quit smoking, call them, okay? Now, blood pressure, the evil blood pressure that I was telling you about, okay? All right, know your numbers. These numbers have changed over the years. Some of you may have much lower numbers in mind. I'm going to tell you that blood pressure numbers have actually changed. So I'm going to give you the newest guidelines, okay? Younger patients, less than age 60, your blood pressure goal should always be less than 140/90. I'm sure everybody's thinking, that's not the 130/80 I heard about. That's not the 120/80 I heard about. Well, because we found out that more and more people, if we do this type of goal, they do better. They have lesser high blood pressures, okay? And that's why we changed the guidelines. What about the older folks? We even do it more liberal, 150/90, okay? Now there's a caveat. There's always a caveat. Diabetics and patients with kidney disease. Doesn't matter. Anybody above age 18, their goal is the same as the younger patients, okay? So 140/90. This is doable. How many of you think that is doable? Yes? Very good. So I think this is where we have to start, okay? Now, I didn't put this in my slide, but I want to tell you guys, when do you measure your blood pressure? Almost everyone here probably has done it incorrectly at some time or the other, okay? So I'm going to tell you exactly when to measure your blood pressure. And this should be a routine. If you have high blood pressure, this should be a routine. First of all, you need to have a blood pressure machine at home. The one I recommend is the pressure cuff with a little button. Don't get the wrist one. They're not accurate, unfortunately, no matter how expensive they are. Okay? Get the one that has a pressure cuff. All right? That's number one. Number two, when do you measure your blood pressure? First thing in the morning after brushing your teeth and before you eat your breakfast or take medicines. How many of you take your blood pressure after you take your medicine? Most of you. I'm sure of it. I'm sure of it. Okay? Well, that defeats the purpose. Guess what? When you get ready in the morning, your body has a specific hormones that gets released. Cortisol, adrenaline, all these hormones. These hormones cause your blood pressure to go up. Now, if you've taken your medicine and then you measure your blood pressure an hour later, what's going to be? It's going to be low, normal or low, but you missed the chance to look at what was your highest blood pressure. All right? Now, most blood pressure medicines last in your system between 12 to 18 hours, typically. Some of them are longer, some of them are shorter. Okay? So when is the second time to measure your blood pressure? Just before supper time, 5, 6 o'clock in the evening. Okay? Before taking your evening medication. All right? So I'm sure most of you have been measuring your blood pressure incorrectly. So we need to change that. This is when you're going to find out that so many of you have had normal blood pressure all your life when you measured it. But guess what? It wasn't really normal. Okay? You just measured it at the incorrect times. And this is why we have heart failure, because of high blood pressure. Doc, my blood pressure is normal. No, it's not. Okay? Because you didn't measure it correctly at correct times. All right? Now, cholesterol goals. Now, goals have changed over the years. There's a lot of controversy in this. Okay? So I'm going to give you simplest goals. Simplest goals. Okay? Total cholesterol less than 200. And for diabetics and people with known heart disease, 160. Less than 160. Total. Okay? Oops. Triglycerides, less than 150. That's for everybody. All right? This is the good cholesterol, the HDL, the high density lipoprotein. You want it to be always above 45 and ideally above 50. And guess what, everybody? The only way to raise that is to exercise. That's the only way to raise it. Medicines barely help. Okay? So that's the only way to get it better, the good cholesterol. The bad cholesterol, okay, the LDL, the low density lipoprotein, okay? Less than 100, if you have a heart disease or diabetes, less than 70. These are your goals. So take charge of your health. Ask your doctor about your numbers. And now you have the numbers to follow, so you know what your goal is. All right, weight goal, all right? Everybody cringes at this. Everybody cringes at this. So I'm a little liberal. I'm a little liberal in this. Everybody's heard of body mass index, right? All doctor's office can calculate this. Any clinic can calculate this for you. Okay? All they need to know is your height and your body weight. Okay? And your body mass index should always be below 30. Okay? Now, let me tell you something. These are the numbers. I haven't made them up. These are the numbers. Less than 19 is considered cachexia, or too low. Between 19 to 25 is considered normal. Between 25 to 29 is considered overweight. 30 to 35 is considered obese. And anything above 35 is considered morbidly obese. Okay? Now, some societies use 30 to 39. They are even more generous, and they say 30 to 39 is obese, and above 40 it's considered morbidly obese. Well, your goal is always less than 30. Okay? And obviously, optimal body mass index is less than 25. Now, if everybody in this room can get to this, I'm happy. Okay? Obviously, I want you to strive to get to this. but I'm happy with less than 30. All right? And this is also another thing that goes along with it. Everyone should have the waist circumference less than 35 inches. Okay? I see a lot of noise. Okay, so let me give you the tools of the trade, how to lose weight. Okay? Like I told you guys. And I'm going to try to speed up because obviously we're losing time here. Okay. All right. So, best way to lose weight. Only one best way to lose weight. Portion control. There has been studies after studies done on a 2,000 calorie United States normal diet. You have to walk 21 hours a day to burn that off. Not possible. Okay? All of these weight programs, Weight Watchers, Nutrisystem, Genecritic, all of them do what? One thing. Portion control. That's how you lose weight. The other things you need to do is heart healthy diet. What does heart healthy diet consist of? Less red meat. That includes both beef and pork. Everyone asks me that question. Pork is considered red meat? Yes, it is. Okay? More poultry and seafood. All right? Cooking meats, this is how you cook meats. Baked, boiled, and grills. Occasionally broiled. Never fried. Okay? Now, there's a saying. I'm going to go real quickly into this. Eat breakfast like a king, lunch like a prince, dinner like a beggar. Okay? What does that mean? Eat a larger breakfast, medium-sized lunch, and a small snack for dinner. Now, why is that? Remember I told you guys about that blood pressure? In the morning you have a lot of hormones to get you ready for the day. Well, those hormones also cause your body to actually break down all that energy that you take in. At the end of the day, you have no hormones left in your circulation. So all that food that you eat, 8 o'clock, 9 o'clock at night, and you go to sleep an hour, it's all turning into fat. Okay? So, I will give you guys, because we are growing up this way, that we eat a larger dinner, so I will give you guys a compromise. If you're going to eat a big dinner, give yourself at least 4 to 6 hours between supper and sleep. Okay? Now, for diabetics, you're allowed to have a small 100 to 120 calorie snack. I do not want you to have low sugar overnight if you're going to eat a small early dinner. Okay? So this is an exception to the diabetics. All right, oops. Now, the last thing I want to tell you about the weight loss, lose slowly. 2 to 3 pounds a month and 15 to 20 pounds a year. Okay? All right, choose healthy. I'm going to go quickly through this real quick, okay? And everybody knows this. I'm just preaching to the choir, so I'm going to go through it very quickly. Shop healthy, fresh and frozen vegetables, not canned, because they have a lot of sodium in them. Okay? Baked snacks, not fried. Okay? And don't be deceived by the looks, and I'll show you the example for that. Okay? Read the labels. Know how to read the labels, and I'll show you how to do that. And then this is, we're going to talk about that real quickly. Okay? So this is a label, typical label, whenever you go buy food. Okay? You start here. Okay? You look at the total calories and servings. Okay? Now, simple math. Everybody can do simple arithmetic. If the total calories is, or if your fat calories are more than 50%, put it away. Move on. So this label, 160 calories and fat calories are 90. So 160 divided by 2 is 80. Is more than 80. Put it away. Okay? That's the simplest math. Everybody can understand that. All right? Then obviously you want to try to limit all this and try to eat more of this. Okay? Simple as that. You need to eat more fibers, okay? More vitamins, less fat. Simple. All right? So don't give in. I'm going to give you a very nice example. Here's the example. Look at this. Look at this. One serving, 330 calories. Calories from fat, 210. Okay? Put it away. Put it away. All right. Okay. Last thing I want to tell you about maintaining your weight. Okay? Use recipe books. Be creative. Okay? Eat out less. In fact, there was just recently a study published. It's just a survey. Okay? And what they found was that if you eat less 50% of the times, okay, average American eats 5 times a week outside the house. That's about 25% of the meals. If you count 21 meals, 3 meals a day, 7 days a week, 21 meals, that's about 25% of the meals. If you reduce that to less than 2 meals outside, you get to live a decade longer. A decade longer. That's a survey study, okay? So, eat out less, okay? When you eat out, always look for and ask for low-fat, low-calorie choices, okay? All right, in between meals, only eat small snacks. Don't give in and eat big things, and eat a fruit, okay? Drink more water, 48 to 64 ounces. Everybody knows this. I'm just giving you guys the same thing. Limit 1 caffeine drink per day, okay? That's it. And I'm nice to my patients. Once a month, you can reward yourself. You're gonna go eat a chicken fried steak? Go for it. Once a month. Okay? All right. Now, let's just wrap up here. Physical activity. Everybody in this room thinks that walking is great for you. Not really. Not for heart. You got to do aerobic activity. Okay? Aerobic exercise. Okay? You got to get your heart pumping. Why? Heart has 2 types of muscle. It has a regular muscle and it has a muscle we call hibernating myocardium. Hibernating is sleepy. Myocardium muscle, heart muscle. Okay? The only way you can recruit that is to get your heart rate up. And the only way you can do that is by aerobic activity. Okay? Aerobic exercise. And if you do that the way I tell you to, you'll be able to live longer, healthier. First thing you do is get a partner. Self-motivation doesn't work. I'm guilty of it. All right? Start slow. 10 minutes every other day. 3 times a week. You can do that. Everybody can do that. Get a bike, go swimming, get a treadmill, or get to the Y and get on the treadmill, stepper, bike, whatever you want to do. Okay? Or go jogging. Build up to 20 minutes every other day. Then go to 20 minutes 5 times a week. Okay? And then top off 30 minutes 5 times a week. Now, you can start this as every 2 weeks. You can accelerate your program. But that's your goal. 30 minutes, at least 5 times a week. Everybody understand that, right? All right. One simple way to get started, all the things that I've told you guys about, it's on this website called heart.org, My Life Check. Some of you might want to write that down. Okay? And then this is all the prevention talk, and I'm going to just talk real quickly about the treatments. Let me know if everybody's ready. heart.org/mylifecheck. Okay? All right. Last thing, treatment of acute heart attack. Everybody knows this, but I'm going to just simplify it for you. Open the clog. The artery is clogged up, open the clog. Okay? That's what we do. That's what our job is. And then obviously we put a stent in, or if we have to do surgery, we have to do surgery. Okay? And then acute brain attack, the stroke. Okay? If you have blockage, you open the clog. There are 2 types of strokes. I didn't tell you about the second type because the number 1 cause of bleeding stroke in the brain is high blood pressure. That evil blood pressure again. Okay? So, and that's what causes the bleeding in the brain. It's the number 1 cause. There are other causes as well. Okay? So, if you have bleeding brain or bleeding in the brain, obviously we have to drain it. All right? Acute heart failure, remove excess fluid and restore balance. That's on us. We have to help you with that. Okay? All right? At the end, however, after fixing all this, treat the risk factors. That's the bottom line. And that's why I spend so much time giving you guys the tools of the trade and giving you guys the guidelines and giving you guys the numbers to take charge of your health. All right. Long-term treatment for cardiovascular disease and heart failure, control modifiable risk factors, hypertensives, cholesterol medications, platelet medicine. This is all on us. This is just something I'm just giving you guys a list. It's just to show you this is what we do. Hormone blockers. This is all the things that we do. Rhythm control medications. We talked about arrhythmias and things like that. Devices, non-invasive, invasive therapy, and at the end, if your heart is failing, obviously, transplant center. Okay? Questions? And this is the number, by the way, for the smoking cessation.
If you have a heart attack, does that necessarily mean you do have heart disease?
Almost definitely, but there are some exceptions. Okay? There are patients who have heart attacks because of coronary spasm. Women have a specific, actually, not just women, but its ratio is much, much higher, women to men. There's something called syndrome X. We are very fancy with our names. The syndrome X is actually something called endothelial dysfunction, or coronary spasm, where you have these large arteries on your heart, normal, but you have lack of blood supply to the smaller arteries, which truly bring blood to the heart muscle. And this disease doesn't actually have significant treatment plan. We have special medicines that we use for. So that's the bottom line of the answer, that not everybody has, severe artery disease like we talk about, like I showed you. Some people don't, okay? Him and then her and him, yes.
Do you have an opinion on the long-term use of PPIs on the cardiovascular system?
Very good question. Very good question. The studies, the jury's still out. That's the bottom line answer for you. Okay? PPI is proton pump inhibitors. These are the medicines, the Protonix, the Prilosec, the Nexium. I'm sure you guys have heard the names. These medicines cause the proton pumps in your stomach to reduce the amount of acid. But there is a caveat to that. We have learned over the years, we meaning the physicians have learned over the years, that there is an inherent change in your stomach. Because you inhibit the pumps, guess what the body does? It produces more pumps. It doesn't get to the cell surface, but they are still produced. So if you ever stop it, you get rebound reflux. Okay? So that's one thing. Second thing is, these medicines, over the course of years, can cause increased cardiovascular risk. And we're talking about more than 5 years, 10 years. So prolonged use can cause cardiovascular risk. But the risk is basically a study that was shown to, there's 2 studies actually. The bottom line is risk is basically this. We took 25 factors between 2 populations, we controlled them. The only difference was this group had PPIs and this group did not. And they found that there was increased risk in the group that had PPIs. But what about the 26th factor we didn't check? You understand? So studies, you have to look at them with a grain of salt. Not everything that's published out there with the risk factors is proven. So that's why I say the bottom line, jury is still out. Okay? Yes, sir?
If you have AFib,
Uh-huh.
you take the Xarelto, that's one of the drugs.
Yes. So he brought up a very good point, and actually I didn't actually discuss at all about the arrhythmias. Atrial fibrillation, atrial flutter, these are the upper chamber of the heart, the atria that I showed you guys in the anatomy picture, okay? What they do is they quiver. In fact, there's a specific thing that happens when they quiver, when you have atrial fibrillation or atrial flutter. There is a special area in your upper chamber on the left side called left atrial appendage. It's basically like a little outpouching, okay? When these upper chambers quiver, they can actually cause blood to stagnate in that area. And that can actually make a blood clot, possibly, okay? Not everybody gets it. We actually specifically have a risk calculator that we look at. The risk calculator goes from 0 to 9, which includes risk of high blood pressure, diabetes, heart failure with a low heart function, history of stroke or TIA in the past, females, just by being a female, you have a risk factor. You have coronary artery disease or peripheral arterial disease, or you have age that is between 65 to 74 gets 1 point, and then at 75 and above gets 2 points. Now, on that risk calculator, if you're greater than 2, your risk is more than 2% per year for having a stroke. And that is moderate to high risk, and you should be on a blood thinner. Xarelto is just one of the drugs. We have been using warfarin, which was the tried and true drug for 45 years. Some of you think it's a rat poison. Well, why do you think it's a rat poison? Because in rats, we don't measure blood thinning power. In humans, we do. We check to see what your blood thinning power is. We want your INR, which is the blood thinning power, to be between 2 and 3 if you're on warfarin. Problem with warfarin is there's 3 major issues. Number 1, it has to have the INR in the therapeutic range. If you're too low, we're not protecting you. If you're too high, you are at risk for spontaneous bleeding. That's one problem. Second problem is if this warfarin is a vitamin K antagonist, meaning it basically antagonizes vitamin K, and there are certain clotting factors that use vitamin K, and if you use warfarin, you will have less clotting factors, hence your blood will be thin. But if you eat a lot of things, green vegetables, leafy vegetables, cabbage, spinach, anything that has a lot of vitamin K, you defeat the purpose of warfarin. So there's a lot of food restriction to warfarin. That's number 2. Number 3 with warfarin is that it has a lot of drug-drug interactions because it processes through the liver. So with those in mind, the pharmaceutical companies came up with alternatives. First alternative was Pradaxa. That's the one that came on the market. It's twice-a-day drug, and it's the only one that has the antidote. I want to tell you guys about it. On head-to-head comparison between warfarin and Pradaxa, the only increased risk of bleeding in the Pradaxa group was, they both were really equal in terms of protecting you from stroke. But in the Pradaxa group, there was an increased risk of GI bleed, okay, from the stomach. So that was an increased risk. So that's why it kind of, a lot of these 1-800-BAT drug came on market and everything. And so, you know, that's why the company came up with the antidote. So now we have an antidote. There are 2 other medicines that we have. One is called Xarelto, and the other one is called Eliquis. I'm sure most of you guys are familiar with these because they advertise like crazy on the TV. Okay? So both of these drugs are as good, if not better, for warfarin. In fact, they have a better bleeding profile, meaning they have less bleeding compared to warfarin. Okay? Warfarin has more brain bleed than these drugs do. And they've actually done analysis after the drugs were released in the market afterwards to see how the bleeding is done compared to the trial, and they seem to be even better. Okay? So these drugs are fairly safe to take. Now, they do not have an antidote, so I want to give you that disclaimer. Okay? But they are very similar to heparin. Heparin, the IV blood thinner that people get when they come to the hospital. So we use these drugs, and we know how to reverse heparin, so we know how to reverse these drugs. Now, I'm not going to lie to you and tell you that these drugs cannot kill you. Warfarin can kill you, and so can these drugs be. Okay? But these drugs are fairly safe in the appropriate population. And you have to let that decision be made by yourself and your physician. It cannot be just a physician telling you, just let's start on Xarelto. No. They have to explain to you why we're going to start you on Xarelto. Why is it safe for you? Okay? So I'm sorry to give you a very, very long answer, but this was a very important question. Yes, sir.
Something about, you said walking was not aerobic.
Exercise, correct. Yes. Now, some will argue with me that they walk on a farm and their farm has hills and stuff like that. Yes, that may be aerobic. You may get your heart rate up. But aerobic activity is different than just general walking. Now, having said that, I want to encourage everyone to walk. I'm not going to lie to you. I'm not going to tell you that don't walk. No, I want you to walk. But on top of that, I want you to do the aerobic activity. Okay? Question. I saw a hand here. Yes, you. Calcium score. Very good. Very good question. Okay? Let me take a sip of water real quick. This one's going to require one. So, what is calcium scoring? So, you know, this was the test that we thought it was going to be great as a screening tool to do on everybody and figure out who is at risk for heart disease. Unfortunately, it hasn't panned out. Now, the guidelines are very, very strict on this. A patient who is younger than 60 years old and who has no more than one risk factor from all the risk factors we talked about, okay, and has no chest pain or no symptoms that we talked about. These patients should and could be screened with calcium score. And if their calcium score is high, then they should have a preventive screening test of ischemia or blockages in your heart arteries. All right? You understood how I chose my words very carefully. Okay? So a lot of patients will fall out of that. Because when you ask patients enough questions, you're going to find that they're going to be symptomatic, so you can't have calcium scoring. And you're going to find that you have more than one risk factor, so you're going to be out of the calcium scoring. So the only thing good for the calcium score is a 30-year-old female who has atypical chest pain. Great test for that young person. Or a 44-year-old or 45-year-old male who has family history of heart disease but nothing other than that. We would love to do a calcium score on that person, to risk stratify that person, to figure out whether or not this person may develop heart disease at a later age. Okay? So that's the answer. Other questions? Yes, Steve?
What would you suggest as an alternative to things like
Anti-inflammatories?
Yeah, the PPIs.
Oh, PPIs. In some cases, we don't have an alternative. So we have to sometimes take it good with the bad. Okay? And so if you are on a long-term PPI therapy, if you're taking it more than 5 years, you should go see a gastroenterologist because the guidelines are changing constantly. The most recent guidelines say that you should have a small break in using the PPIs with the full known knowledge that I told you about, that rebound reflux phenomenon. Even then, you should have a break for a few months to prevent you from having significant bone loss and prevent you from having cardiovascular disease. But unfortunately, like I said, the jury is still out. We don't know if this is really causing heart disease. We think it may be, but we don't know yet. So we may come up with alternatives. There's always more drugs coming on the market, but right now there's really no clear alternatives. Yes, Steve? Okay. You mean supraventricular tachycardia, proximal supraventricular tachycardia? Yes and no. You knew my answer was never going to be straightforward, right? Okay. She mentioned something about paroxysmal supraventricular tachycardia, PSVT, okay? Paroxysmal means occasional. Supraventricular meaning that it comes from upper chambers, not the lower chambers. Remember the two lower chambers, two upper chambers, okay? So that's what it means. That's what the tachycardia means, fast heart rate. Okay, so that's the definition. Occasional, upper chambers, fast heart rate. If you are in long-term paroxysmal supraventricular tachycardia, you can have something called tachycardia-induced cardiomyopathy or weakened heart muscle. Remember I mentioned something about arrhythmias causing heart failure? Well, paroxysmal supraventricular tachycardia, if you are in there all the time, then it can cause you to have heart failure. It can weaken your heart muscle. But it's easily fixable. We have lots of medicines to control those rhythms. Okay? So the answer is yes and no. If you're in all that time, yes you can. If it's very well controlled, no heart failure. Okay? One last question, anybody? Any last dying question? Yes, sir.
The symptoms that you have for heart attack
Mm-hmm.
seem like it's everything else, but is her heart doesn't actually hurt, or
Very good
does
question.
everything else hurt?
Very good question. I didn't bring that up in the anatomy lecture. Okay. First and foremost, how many people think that heart has nerve endings? Heart has nerve endings, like every other organ does. Heart has no nerve endings. What a surprise. So where do you get this chest pain from? Where do you get the chest pressure from? Because when the heart strains, it translates the sac around the heart, which is called the pericardial sac, okay? And the sac around the heart also strains. And that sac does have nerve endings, okay? So when the heart strains, it causes the strain on the sac around the heart, which is what we call referred pain. And that's why sharp pain is not a heart pain. Chest pressure, heaviness on the heart, which is not the typical pain of a muscle that you would describe. When you pull your muscle, what happens? Sharp pain, right? That's not what you get with the heart. You get chest pressure, okay? So the heart does not have any nerve ending. It's the sac around the heart that causes the pain. Very good question. Okay. Thank you all for being very lively audience.